Good evening, everybody. Well, I'm indeed honored to be a part of today's session. And I thank the Endocrine Society of India, the President, Dr. Sanjay Kalra, Dr. Saptarshi, Dr. Sheila, for the opportunity given to me. We are indeed privileged to have eminent dermatologists with us, Dr. Asik Mittal from Udaipur and Dr. Sonja from Germany. And I'm sure their presence and participation today in this meeting will enrich our knowledge on dermatoendocrinology.
Ma'am, full screen, please.
We are also eagerly waiting for the comments of our international endocrine colleague, Dr. Payal. And I appreciate Dr. Shyam Sundar for the excellent quiz he has conducted. Well, the chairperson has given a very, very nice introduction and a summary of today's topic. Then, as he already said, endocrine disorders often first present to the dermatologist. So the dermatological manifestation not only helps in diagnosis of the endocrine disorder, but also helps in monitoring the treatment of the disorder. So that's why the skin is called the mirror to the body. And then some of the common clues for a hormonal basis come from the skin as well as its appendages. So some examples depicted in this slide are, you can see a characteristic body odor of acromegaly, the dry hair of hypothyroidism, sweating disturbances like in hyperthyroidism, acromegaly, and even pheochromocytoma can be added here. Then hirsutism, all androgen excess states can produce a number of conditions. Alopecia and terogem, again, autoimmune markers and do occur with hypo and hyperthyroidism. Skin pigment abnormalities, ACTH excess and deficiency are responsible. A skin texture thickening is because of the anabolic actions of growth hormone and IGF-1 like in acromegaly. The skin thinning is due to the catabolic effects of cortisol as obvious in Cushing's disease. And then generalized pruritus in a number of conditions. So this we are aware for so many decades, but as the chairperson rightly said, the skin is now an endocrine organ. So there is a cutaneous endocrine system in the skin. So the skin synthesizes hormones, there are enzymes present, there are receptors present in the skin. To name a few, the 5-alpha reductase 1 converts testosterone to dihydrotestosterone in the skin, especially the scalp and the face. Then of course we have the thyroid and the androgen receptor. You can see TRH, CRH, MSH are all present in the skin and their receptors are also seen. The skin synthesizes IGF-BP3 in addition to the liver, and the PTHRP is also synthesized in the skin. So prolactin and vitamin D are also synthesized in the skin. So the prevalence of, well, I will confine, I'm not going to go into the dermatoendocrinology part, but I'll confine myself to the cutaneous manifestations of endocrine and metabolic disorders. So the prevalence of the cutaneous manifestations is quite high. If you look at the common endocrine and metabolic disorders, diabetes, 70 to 80% have skin manifestations. Thyroid disorders, 60 to 70%, and Addison's disease, again, almost universal skin manifestation. So the skin signs, again, which point to an endocrine disorder, they may be specific or they may be non-specific. So some of the common signs which we see are, let me start with acanthosis nigricans. So this is again a picture of acanthosis nigricans. So you can see a thickening of the skin and the nape of the neck, the hyperpigmented plaque-like appearance with a velvety feel. So many conditions of insulin resistance can produce acanthosis nigricans. So one of the questions of Dr. Shyam was acanthosis is seen. Remember, in addition to acromegaly, hyperprolact anemia through increase in the IGF-1 can also lead to acanthosis nigricans. Acne, again, a common skin disorder, a very important cosmetic problem, is again can occur in so many endocrine disorders, glucocorticoid therapy, Cushing syndrome, and all androgen excess states. Well, acne points to an endocrine disorder if it is occurring suddenly at a later age, and if it is resistant to conventional therapies, it is a good marker of androgen excess. Then, cutis verticis gyrata, a specific scalp disorder, again can be seen in acromegaly. This is again because of increase in collagen in the dermis, leading to buckling of the skin. Granuloma annulare is specific to diabetes. Hypertrichosis is seen in many endocrine disorders. Necrolytic migratory erythema is specific for glucagonoma, and so is scleroderma for diabetes. So these are some of the signs which point to endocrine disorders. Well, this diagram is the necrolytic migratory erythema, which is specific for glucagonoma. So I would like to discuss the cutaneous manifestations as per taking each endocrine organ dysfunction. So I would like to start with the pituitary. So the mucocutaneous manifestations of acromegaly, these are usually present at the time of diagnosis. So they're usually universal, they're present at the time of diagnosis. And they're all because of the mucocutaneous manifestations are because of thickening of the skin and the soft tissues. So macroglossia, macrokelia, gingival hyperplasia, coarse facial features are all because of the soft tissue and the skin thickening. Then hyperpigmentation in acromegaly is because of an increased pigment production. Acanthosis again occurs because of the metabolic syndrome. There is an increased sweating, there is an increased vellus hair, and then you have a typical flat broad nails called as platynegia. So these manifestations of acromegaly do ameliorate to a certain extent when you treat the disorder. The disorder is cured. Then comes hyperprolact anemia. As I said, because it increases the IGF-1, there is a limited overlap in the cutaneous phenomena seen in acromegaly. The example is acanthosis nigricans. And the typical manifestations of hyperprolact anemia are, as far as the skin is concerned, are the SAHA, the mnemonic for seborrhea, acne, hirsutism, and androgenetic alopecia. This is all because of an increase in the adrenal androgens. Hypopituitarism, the skin phenotype is dominated by the main hormone which is produced in insufficient amounts. So the ACTH absence leads to pale hypopigmented skin. GH and prolactin deficiency lead to skinning of the thin, a reduced sebum production, and reduced sweat secretion. So all this produces a picture of wrinkling of skin around the eyes and the mouth. And in addition, you have a decrease in the hair and the nail growth. Well, thyroid disorders, we all know that thyroid hormone is very essential for the skin, the keratinocytes of the epidermis, the fibroblasts of dermis, all they need the skin formation. We need the thyroid hormone. So is the hair formation and the sebum production. So hypothyroidism, again, cutaneous manifestations are quite obvious. So the dry skin, cold mottled skin is all because of vasoconstriction and because of the decrease in the keratin turnover. Then the classical cutaneous manifestation, the myxedema, is the term given to the classical skin manifestations of hypothyroidism. In addition, macroglossia, there is a loss of lateral third of the eyebrows. Again, this was another question put by Dr. Shah. Madarosis, that's called the Queen Anne sign or the Hethoff sign. There is a coarse brittle hair, and beyond these coexisting autoimmune disorders produce autoimmune urticaria, vitiligo, and alopecia areata. This is one of our patients. So you can see the typical myxedematous appearance. So untreated congenital hypothyroidism, we did have children like this. She was 20 years old when we saw her, maybe 5 years or 10 years back. You can see the periorbital puffiness, the fleshy lips, the supraclavicular fullness, very typical of myxedema. Well, the mucocutaneous manifestations of hypothyroidism do again resolve when we treat hypothyroidism. Moving on to cutaneous manifestations of hyperthyroidism. So they are all because of thinning of the skin and vasodilation. So the warm, moist, smooth skin, flushing, palmar erythema are all because of the skin thinning and vasodilation. There is an increased sweating. There is a diffuse scalp hair thinning, onycholysis, pretibial myxedema, thyroid acropathy is rare, generalized pruritus, and chronic urticaria. This is again a picture of onycholysis. So you can see that onycholysis is the separation of the distal nail plate from the nail bed, and this is what is called the dirty nails. It is first obvious in the 4th and 5th fingernails. I don't know the reason why, but then they do ameliorate with treatment of thyrotoxicosis. Well, this picture is taken from the article Dirty Nails published in JCEM. Again, a very important series published in the JCEM is the Thyroid Dermopathy, a series of about 78 patients. And there were 5 different types of thyroid dermopathy which are described there. So the first picture A is the typical pretibial edema. B is the pretibial plaque. If you see C, you see nodules in the ankle, around the ankle and the feet. D is the elephantiasis, and E is scar, in a scar, dermopathy in a scar. So there are so many different variants of thyroid dermopathy. And remember that thyroid dermopathy is a very, very important extrathyroidal manifestation of Graves' disease. However, it doesn't go parallel with thyrotoxicosis treatment. You may treat thyrotoxicosis, but still the dermopathy may not resolve. So treatment is difficult. Mild forms resolve with topical therapies, but severe cases are resistant to treatment. Well, parathyroid glands, again important for skin health. The PTHRP is synthesized in the skin. There is a PTH and the PTH receptor signaling now identified in the skin, and skin hair nail changes are described with parathyroid dysfunction. Primary hyperparathyroidism, the symptoms are quite subtle. There's a mild pruritus. There's a dry skin and mucous membrane secondary to dehydration. Secondary hyperparathyroidism, because of metastatic calcification, can produce calcinosis cutis. These are erythematous indurated papules. So these, you can see the picture of calcinosis cutis with an ulceration, and usually seen on the extremities. Hypoparathyroidism, mucocutaneous manifestations are well described by Indian authors from Calcutta. Dr. Sakar S. et al. From India has published the mucocutaneous manifestation of acquired hypoparathyroidism in IJAM 2012, quite high in as much as 76% of patients. So the skin changes are xerosis, pellagra like hyperpigmentation, pustular psoriasis, and an acne-like eruption. Hair, you find loss of axillary pubic hair, coarsening of body hair, and alopecia. Nails are brittle, ridged, and there can be onycholysis. Well, the adrenal gland, again, the classical syndrome of hypercortisolism is the Cushing syndrome. So the skin manifestations of Cushing syndrome are all because of alteration in the subcutaneous fat deposition. So the moon faces, torso-cervical fat pad, the supraclavicular fat pad are all because of the subcutaneous fat deposition. This is one of our patients. You can see the typical moon face-like appearance. Then the facial plethora, easy bruising, delayed wound healing, skin atrophy are all because of thinning of the skin. The skin atrophy is responsible. The breakdown of the collagen is responsible for all these features. Then hyperpigmentation occurs because of an excess of ACTH in ectopic ACTH syndrome and Cushing's disease. Acanthosis nigricans, again because of metabolic syndrome. Well, steroid acne and hypertrichosis are also other manifestations. Well, this is a picture of striae. You can see what is important about the striae. The striae are violaceous purple. You can see they're more than 1 centimeter in width. This is again another girl who came with hypertrichosis, which is obvious on her face. She received injections of, she and her sister, both of them received Kinocort injections from a general practitioner, and this was the concern for which they came. Well, Addison's disease, again, mucocutaneous manifestations are universal. There's a diffuse cutaneous hyperpigmentation, especially the sun-exposed areas. So there is pigmentation of nevi, there is pigmentation of hair. Again, a question of Addison's was posed by Dr. Sham. Remember that hair hyperpigmentation is a feature. There is also repigmentation of the gray hair also. And then mucosal hyperpigmentation. There is loss of axillary and pubic hair. This is because of the absence of the adrenal androgens. And there are longitudinal hyperpigmented nail bands. Again, one of our patients showing the the buccal pigmentation on the tongue and the lips. So the mucosal pigmentation can be a marker, can be a sensitive indicator of the monitoring therapy. Pheochromocytoma, dermatological manifestations are rare. It is usually an intermittent facial flushing, hyperhidrosis, and a paroxysmal facial pallor. But however, fixed lesions have been described like aggravation of Raynaud's phenomenon and libido reticularis. So this is again a publication in JCEM which showed libido reticularis in the figure A. And on treatment of pheochromocytoma, there is amelioration of the libido reticularis. Well, ovary, again, estrogens are important for the 17-beta estradiol, also is important for the skin texture and the skin health. So hyperestrogenic states where women use oral contraceptives, phytoestrogens or estrogen-producing tumors can have melasma, telangiectasis, and candidal vulvovaginitis. Hypoestrogenism, like in menopause, can have female pattern hair, balding, and skin changes. Well, cutaneous manifestations of androgen excess in women. We are all aware that is hirsutism, and then acne vulgaris, as I said, is an important manifestation. There's a female pattern hair loss. This is the term now used for androgenetic alopecia. So you can see the thinning of hair on the vertex in this patient. And of course, seborrhea is again due to increased sebum production by the androgens. Again, one of our publications was this postmenopausal lady who came with hirsutism. We evaluated her, the case of a Leydig cell tumor of the ovary, and a very rare association was she had a primary hyperparathyroidism. Of course, the hirsutism and decreased after surgery was done. Well, testis, androgen receptors, receptors are there in the skin, and as I already said, androgens maintain the skin thickness, the hair on the skin, and the pigmentation of the skin. So hyperandrogenic states, you do have an increased skin thickness, hair, and pigmentation, and the reverse happens with hypogonadism, where you find the skin is smooth, soft, and there is absence of hair. So the next, I move on to multiple endocrine syndromes. So these syndromes are important for us because the cutaneous features often help in identifying these syndromes. The endocrine manifestations come later. And the reason for the cutaneous manifestations are the specific genetic mutation in these syndromes. So we'll discuss this under the tumoral syndromes and the non-tumoral familial syndromes. So the tumoral syndromes with skin manifestation, I start with the MEN1 syndrome. So the endocrinopathies of MEN1 are parathyroid, pituitary, and pancreatic tumors. So the classical dermatological lesion that is described is the facial angiofibroma. And then this is present in almost 80 to 90% of cases of MEN1. It precedes the endocrine manifestations. And the less common are the collagenomas and lipomas and neuromas. A coexisting hyperparathyroidism produces calcinosis cutis, and then of course flushing due to carcinoid and necrolytic necrotizing migratory erythema if there is a glucogonoma. So this is again a picture of the facial angiofibromas. You can see the fleshy papules on a number of them on the nose and then the face. And the lower picture is the collagenomas. So the picture is from JCM article. So very important is more than 3 facial angiofibromas plus a collagenoma has a very high sensitivity and specificity for diagnosing MEN1 even before the endocrinopathies evolve. Well, then MEN2A cutaneous amyloidosis. So this is a picture of cutaneous amyloidosis. So the picture is taken from the article published from the All India Institute of Medical Sciences, Delhi. The article is a rare manifestation of MEN2A and cutaneous lichen amyloidosis in a family with RET mutation. So the mutation, the RET mutation, which has a mutation at codon 634 rarely is associated with amyloidosis. But however, this particular family had that mutation and they did have amyloidosis. Well, the same picture is you can see in Williams' textbook of endocrinology. This is another patient of ours who had, you can see the ganglioneuromas on the lips and then the tongue. So then other tumors are the tumors which have tumoral syndromes which have Kefele as a skin manifestations. So the differential diagnosis usually is between a McCune-Albright syndrome and neurofibromatosis 1. So the Kefele spots of McCune-Albright syndrome have a ragged edge comparable to the coast of Maine, and then they do not cross the midline. They have their segmental in their distribution. Whereas neurofibromatosis 1 have a number of Kefele spots, the coast of California having a regular edge. There are more than 6, and then you have so many other cutaneous manifestations like neurofibromas and iris hematomas and nevi. So the lentigens and endocrine syndromes, we have examples here, the Leopard syndrome, the Carney's complex, and the Cowden disease. So these are all syndromes which have a spotty skin pigmentation associated with the endocrine hyperactivity and then endocrine and non-endocrine tumors. Again, there is another question which I would like to answer here. This is the Carney's complex. What is rare in Carney's complex is Kefele spots are rare. So the common ones are lentigens, blue nevi, and cutaneous myxoma. The non-tumoral familial syndromes, the skin manifestations are the autoimmune polyendocrine syndrome 1. This syndrome is there is a hypoparathyroidism, adrenal insufficiency, and hypogonadism, hypothyroidism. So, this particular syndrome, the very important cutaneous manifestation, again, almost universally present is the mucocutaneous candidiasis. So it precedes again the endocrine picture. So this is a picture showing the fungal infection of the nails and the paranachia. Then alopecia areata and vitiligo also occur less commonly. So this is again one of our patients with alopecia areata and coexisting hypothyroidism. So treating hypothyroidism does resolve alopecia areata to a certain extent and in some individuals. So the autoimmune polyendocrine syndromes 2 and 3, there's only the hyperpigmentation due to adrenal insufficiency. And then there are other syndromes like the AHO and the tuberous sclerosis, which also have a combination of dermatological lesions and endocrinopathies. So a word about vitiligo and the increased prevalence of thyroid dysfunction and diabetes mellitus in Indian vitiligo patients. So Indians do have, it is important that vitiligo patients be screened for thyroid and diabetes disorders. Well, the last part of my presentation is about diabetes and lipids. So the cutaneous manifestations of diabetes are because of hyperglycemia, hyperinsulinemia, and microangiopathy. So there are a number of cutaneous manifestations which all of us are aware. The most specific, though rare, is the necrobiosis lipoidica. So this is a very typical picture showing the necrotic erythematous lesion on the leg, and this is the histological picture. What Dr. Sham said is the stacked Lasag appearance. Then diabetic dermopathy is the most common cutaneous. Maybe if we leave infections, I think diabetic dermopathy is the most common cutaneous manifestation. Again, diabetic bullae are rare, but of course they are specific for. Then scleroderma again occurs with diabetes, acanthosis, carotenemia, lipodystrophy, hemochromatosis, and xanthomas and infections. So this is again our patient. This girl had lipodystrophy, which is very obvious. You can see the prominence of musculature, absence of subcutaneous where she had diabetes. A very important for endocrinologists is to examine the insulin injection sites for lipohypertrophy, especially in children, type 1 diabetes children taking a number of insulin shots daily. So, this is again a very interesting case which we had. So this boy was a type 1 diabetic who was attending our department for the last 10 years. So his presentation was with the Norwegian scabies. These pictures have been shared by our endocrine, our dermatology colleague, Dr. Raghurama Rao. You can see the isolation of the itch mite. It's an extensive crusted scabies. The boy was treated successfully, and last week, this is his picture when he came to the OPD. So finally, lipid disorders also have cutaneous manifestations. The hypertriglyceridemia and beta-lipoproteinemia have eruptive xanthomas as obvious on the knees and the elbows. So you can see the yellowish papules with an erythematous base. So this is eruptive xanthomas. And of course, familial heterozygous hypercholesterolemia again presents with a number of xanthomas like the tendon xanthomas and the tuberous xanthomas like in this girl. So I think with this, I have finished my short presentation, and I'm sure whatever I have missed or will be added by our expert panelists. So the take-home messages of today's presentation is dermatological features provide important clues to associated endocrinopathies. The skin findings may be a hallmark lesion. They may be the first clinical sign of the endocrine syndrome. The very complex interplay between hormones and skin. So the subject dermatoendocrinology is going to be the future. And skin as an endocrine organ may provide new avenues of endocrine disorder management. Well, once again, I thank all the expert chairpersons for listening to me. I thank the delegates and I thank the host for this opportunity.